In our clinical setting, ideal patients for mapping or staging biopsy are those patients who are NCCN low or intermediate risk, very low risk or positive select MDX, a prostate health index greater than or equal to 36, low or intermediate risk PIRADS 2 score, and overall many patients who may be eligible for active surveillance or targeted focal therapy should have 3D staging biopsy to rule out the possibility of high-grade disease. The equipment needed during a 3D mapping biopsy is a B&O suppository, sterile water and lubricant, a biopsy grid, 1 to 2% lidocaine with epinephrine, a Foley kit, gold fiducial markers, and 2 biopsy guns. Before surgery, the patient is given IV Ancef 1 to 2 grams. Other equipment needed are a Civco brachytherapy stand with a stepping unit and a BK Flex focused ultrasound or equivalent. When positioning the patient, make sure the patient is supine in stirrups and the patient's legs are parallel with the bed. To prep the perineum, we use a betadine scrub kit. After prep, insert a Foley catheter and apply 10 to 15 cc of lidocaine with epinephrine percutaneously. Insert the transrectal ultrasound on the mounted stepping unit. And make sure the urethra is centered midline on the grid. Insert 2 gold fiducial or fixie needles into the left mid and right mid zones of the prostate. These are to be used in future focal therapy to realign the prostate. Next, collect transverse images every 5 mm using the stepping unit from apex to base for 3D software reconstruction. The software takes these 5 mm 2D ultrasound slices and converts it into a 3D image. Biopsy's new needle will significantly reduce tissue fragmentation because of the teeth embedded onto the biopsy needle itself. 3D Biopsy is also developing a new software that will allow for transperineal MP-MRI fusion biopsy, as well as standard transperineal 3D mapping biopsy. Much like our proprietary software, the software converts 2D images to 3D, but it allows for real-time needle tracking. Here we can see the real-time transverse needle alignment within the software, as well as real-time sagittal needle alignment within the software. This software, once released, will create an extremely accurate 3D map of a patient's prostate and will open the door for new, truly focal targeted therapies. Drs. Crawford and Shore, along with their research teams, developed an algorithm based on a PSA of 1.5 for how to best utilize genomic biomarkers as a screening tool to identify patients who may be harboring clinically significant prostate cancer before and after prostate biopsy. Here, we demonstrate how blood, tissue, and urine markers can be used in a stepwise fashion. Further information, including a copy of this algorithm, as well as patient resources, can be found on our website, pcmarkers.com. Here, we present a 59-year-old patient who was downgraded to ASAP from Gleason 6 and had 2 negative 12-core biopsies as recent as 2 months before their visit with Dr. Crawford. His PSA was 6.8. He had a 60-gram prostate with a PSA density of 0.113. Here we ordered several different genomic markers on this patient. The SelectMDx demonstrated increased likelihood of any cancer with 12% greater than or equal to Gleason 7. His prostate health index was elevated at 71, and the ConfirmMDx was positive in the left apex. The patient's multiparametric MRI demonstrated a PIRADS3 lesion in the lower right peripheral zone of the prostate. This 3D image depicts the area of ASAP that was found on truss biopsy. Although his doctor recommended active surveillance, the genomic markers we ordered compelled us to do a 3D mapping biopsy. As you can see, the results found several areas of high-grade, high-volume Gleason 9 cancer in the anterior prostate. We also found areas of high-volume Gleason 6, 7, and 8 prostate cancer. The patient subsequently underwent radical prostatectomy. The diagnosis and foci location was an exact match to what was found on 3D mapping biopsy. The black lines, depicted on the transverse image to the right, depicts the pattern and biopsy specimen length sampled during a 12-core biopsy using a standard length biopsy needle. The patient was presented with an elevated PSA and a low relative PSA density. His truss biopsy and MRI were both falsely negative. The SelectMDx, Phi, and ConfirmMDx demonstrated increased risk, and the 3D biopsy and RRP demonstrated significant disease. Postoperatively, the patient had an undetectable PSA of less than 0.01. About 40% of our mapping cohort need definitive therapy, 15% are staged with very high-grade tumors, and about 25% of index lesions are anterior. In our clinical setting, ideal patients for mapping or staging biopsy are those patients who are NCCN low or intermediate risk, very low risk or positive SelectMDx, a prostate health index greater than or equal to 36, low or intermediate risk PIRADS2 score, and overall many patients who may be eligible for active surveillance or targeted focal therapy should have 3D staging biopsy to rule out the possibility of high-grade disease. The equipment needed during a 3D mapping biopsy is a B&O suppository, sterile water and lubricant, a biopsy grid, 1 to 2% lidocaine with epinephrine, a Foley kit.
We can cut the video, please. Thank you. We have Dr. Crawford come up and see if we have any questions from the audience.
Dave, as you're walking up here, I do have a question for you. You don't have to hurry. I'm long-winded. Each of the biopsy approaches and things we do have strengths and weaknesses. The transperineal approach has been established as being particularly strong anteriorly and at the apex, but potentially problematic at the capsule posteriorly. When you showed your pictures, you could see a little bit of indentation of the prostate from the ultrasound. What do you guys do to make sure that you're getting the most posterior biopsies when you're doing a transperineal biopsy?
Well, we've learned a lot in the past few years over doing about 1,000 of these, and you're right. And so we adjust the dots down and the lines. We get capsule, things like that. The results have been, as we said, about 30% of the ones we do are people that are low risk or have negative biopsies, and they turn out to have badness. I've done probably 55 radical prostatectomies on men that have had mapping biopsies, and the correlation is really 1-to-1 with the radical prostatectomy specimen. As a matter of fact, we've had a couple of cases where we found higher grade cancers that were missed on the whole mount. So I think there's no question that mapping biopsy was without a doubt the best way to interrogate the prostate. The problem is it's time consuming. You don't get reimbursed for your time. You have to use a general anesthetic, although we're switching over to local now. But we're trying to make it better with that needle that you can dial up to 5 to 6 centimeters. That makes a big difference in the program. So
one of the things that we talk about, but I don't know that it's been generally proven, is the infectious complications rate transperineally are lower. Is that what would you say from your series? You've done a lot of them, do a lot of biopsies. What % of the patients end up with a systemic bacterial infection?
Well, when we started this over 10 years ago, we didn't know, if there would be any difference, and we weren't that worried about transrectal biopsies and infection at that point. And we saw we gave that person Ansep. That was something we've been doing for 10 years. We haven't stopped it. And Priya, what have we had? 1 or 2 infections, I think, out of 1,000, which is not very many. We've actually published on that.
Yeah, I think one of the cost savings with the transperineal is the reduction in treating people who develop the infections post-transrectal biopsy.
I don't think there's any question. This is a needle prostatectomy. And, the whole thing about targeted focal therapy is you got to have a target. And this is why I think it's really the way to find out what's going on.
Thank you so much. I have one more question. Sorry to. So, in the context of MRI, what do you think is the role for 3D mapping biopsy? If you're going to do a 3D mapping biopsy, then why do you need the MRI, for example?
You don't.
Okay.
So here's how I think it goes. PSA of 1.5 is a great cutoff. 70% of men don't need to have anything done because they're less than 1.5. 1.5 to 4 is the gray zone. That's when you do genomic markers. It's like the A1C hemoglobin. If your blood sugar is elevated, you don't get started on an insulin or metformin. You get another test, and it's called an A1C hemoglobin. I think that in that point, that some of these tests are very helpful. And then not everybody needs mapping biopsies, but I think also that people that have like a negative biopsy and have a confirmed MDX or something like that that's positive, that's a perfect place for MRIs. I think there's a marriage where these things can work together. Mapping biopsies are not for everybody, and MRIs are not for everybody.
Great. Thank you so much.